We'll go ahead and get started because I'm sure Maddie has a lot to cover. So we're going to get started with our first CE of the year, our first PGY1 CE of for this residency class, Dr. DeCenzo.
Hi, I'm Maddie. Thank you guys for coming to listen to my CE today. We're going to talk about some strategies for the management of beta blocker and calcium channel blocker overdose. Just to get through some of the housekeeping before we get started, I don't have any disclosures to make anyone aware of. And then these are going to be some of the abbreviations that kind of pop up throughout the presentation as we go along. So to start out, we have some of the learning objectives for the lecture. So we're going to review the pathophysiology of calcium channel blocker and beta blocker overdose and differentiate the manifestations based on mechanisms of each drug class. Describe clinical trial data on efficacy and safety of high-dose insulin therapy versus traditional interventions in calcium channel blocker and beta blocker toxicity. Review adjunct therapies for refractory toxicity, and then select an appropriate patient-specific treatment regimen. So just to give a little bit of background on the prevalence of this kind of overdose currently, a report from the National Poison Data Center that was published in 2023 kind of gave an overview of cases throughout the year. So there were around 30,000 cases reported in 2023 of beta blocker overdose, with about 25 reported cases of death, and then around 17,000 of calcium channel blocker overdoses reported in 2023, with 39 cases of death reported. Most of the reports were in adults that were over 20 years old, and the majority of the overdoses were intentional, according to that report. To go into the pathophysiology specifically of beta blocker overdose, this is a beta adrenergic receptor antagonism in myocardial cells. It causes negative chronotropy, inotropy, and conduction. It decreases contractility. And then when you look at the specific physiology of the different beta blockers, just remember that the selective are the bisoprolol, esmolol, atenolol, metoprolol, non-selective, carvedilol, labetalol, sotalol. And then the most lipophilic is propranolol. And it is important to recognize that as you take more and more of these agents in, the selectivity of those that are selective decreases with a higher level. As far as presentation, some of the symptoms you'll see will be hypotension, bradycardia, altered mental status, hypoglycemia, and you can have heart block and changes to EKG. The symptom onset is around 6 to 8 hours, but in an agent that is more of an extended release, that can be delayed up to 24 hours. So depending on the agent that you suspect the person has ingested, presentation can appear later on. For calcium channel blocker physiology, it's an inhibition of L-type voltage-gated calcium channels to prevent intracellular influx of calcium that's needed for vascular and myocardial contraction. So you'll have decreased contractility, negative gerometrophy, inotrophy, and chronotropy. And then an additional sort of effect is this pancreatic L-type calcium channel inhibition, which is important for the presentation specifically of calcium channel blocker overdose. In addition, as you overdose, as you take in more of these specific agents, you can your kinetics switch to zero order. So you're going to have a prolonged half-life of the agents, the higher level that you ingest. And then just to really quickly go over like the different types of calcium channel blockers, the dihydropyridine, amlodipine, nifedipine, and nicardipine are more selective for vascular smooth muscle cells, where the non-dihydropyridine, verapamil, and diltiazem are more selective for the receptors in cardiomyocytes. So when someone ingests a large amount of calcium channel blockers, they're going to present with hypotension, bradycardia, altered mental status, also the heart block and changes to EKG, but then differently than beta blocker overdose, you'll see more of a hyperglycemia. And that's because of the blockade of the calcium channels in your pancreas, causing decreased insulin resistance or decreased insulin release and increased insulin resistance. Um, Initially as well, reflex tachycardia has been noted in cases of dihydropyridine calcium channel blocker overdose. And then like with beta blockers, the time to symptom onset is going to differ between your ER and your IR formulations. So it can present a lot quicker in an IR formulation, where an ER formulation can take up to 16 hours. So we're going to do our first knowledge check. So which of the following mechanisms best explains the unique metabolic effect of calcium channel blocker overdose? A, increased hepatic gluconeogenesis resulting from sympathetic activity. B, impaired release of insulin from pancreatic B cells due to L-type calcium channel inhibition. C, stimulation of glucagon release from pancreatic alpha cells. Or D, adrenergic blockade leading to reduced insulin secretion. Yes, it is B. So remember, the pancreatic B cells are inhibited due to the L-type calcium channel inhibition in the pancreas when you overdose on a calcium channel blocker, and that's how you can get sort of the more hyperglycemic effect in the presentation. So for initial management, I have kind of what the European guideline looks like versus what AHA looks like. So this is kind of the European guidelines, like step by step for how to treat. The big differences that are going to be recommended here versus in the AHA guidelines are that there's no mention of GI decontamination in the AHA guidelines, and we're going to talk about it later. And it's um, anyway, sorry. Um, there's no GI decontamination listed in the AHA guidelines versus these guidelines, and this is kind of just like a step by step. It's not necessarily like recommend, don't recommend. They do say that intralipids are a form of therapy that for patients that are non-responsive, which we will go over later in the presentation, but specifically in AHA, they say that intralipids don't provide any benefit down here at the bottom. And it's the same for beta blocker. So we'll talk a little bit about GI decontamination. Again, it's not an AHA recommendation. There has been some evidence for use in patients that present within 1 to 2 hours of ingestion at a dose of 500 to 100 grams PO one time. But they cause a lot of issues: nausea, vomiting, respiratory depression, altered mental status. There's a really high risk of aspiration, and can hurt patients that are hemodynamically unstable. And so the first one was the activated charcoal, and then whole bowel irrigation is the other option. The main goal is kind of to just flush the drugs out of your GI tract. Again, it causes a lot of hemodynamic instability. It's very rarely used, and it's not recommended in AHA. The only evidence that we have, which we'll go over a little bit later, is in overdoses of multiple agents, where these specific agents are like make up a small amount of the patient population. Then we have atropine, which blocks acetylcholine action at the parasympathetic sites in the smooth muscle in your CNS and secretory glands, and it can increase cardiac output. This is specifically recommended in patients who have symptomatic bradycardia in this type of overdose at a dose of 0.5 to 1 milligrams every 2 to 3 minutes. There's not a lot of strong evidence for this use specifically either. And because of the fact that it can subsequently affect your blood pressure, and these patients are hypotensive, you can get cardiac collapse. So we don't typically use it in our patients who present with hypotension at the same time. So it's not common. And then IV calcium will increase your blood pressure, improve contractility. You can give it as calcium chloride 10% or calcium gluconate 10%. The calcium chloride is a 1 gram bolus over 60 minutes, and you can do an infusion of 20 mg to kg per hour titrated. And then calcium gluconate would be 2 gram bolus followed by another 1 gram IV bolus. Typically, in our protocol, we just treat patients with boluses. We don't move on to infusions. If we have to move on to an infusion, we'll try something else. And then when you're giving this therapy, it's important to monitor calcium every to 30 to 60 minutes. We monitor phosphorus every 12 hours. We do continuous EKG. And our goal serum eye calcium is 1.5 times the upper limit of normal. And then the last thing is glucagon, which can increase inotropic and chronotropic effects. It's recommended only in beta blocker overdose, not in calcium channel blocker overdose. You give a 5 to 10 milligram bolus, and it can be followed by an infusion, but it can cause nausea, vomiting with rapid infusion, and tachyphylaxis. And again, you need a really big dose. And with those adverse effects, it's not super common that we see this used. And the current evidence, again, for all of these is very limited. So there were a couple major trials looking at GI decontamination and overdose of several different agents, but there was a small portion of patients that were represented by calcium channel blocker, beta blocker overdose. Glucagon, evidence we have is mostly based on case reports. Some have hemodynamic improvement, some patients did not. And there was one human randomized trial that showed a benefit in patients that overdosed on esmolol, but the doses were non-toxic. Case reports with mixed results for atropine in patients with symptomatic bradycardia, and then there are some case series with hemodynamic improvement with calcium, but most of these patients in these patient populations required additional therapy anyway. The next thing we're going to talk about are vasopressors. So along with high-dose insulin therapy, these are the only things recommended, like first line in these specific patients to help improve hemodynamic stability in both types of overdose. The recommendation for a specific agent, one over the other, is based on their site of action. So norepinephrine is an alpha-1 stimulator. Epinephrine has beta-1 and alpha-1 stimulation. It can cause increased heart rate, contractility, and blood pressure. And then dobutamine typically hits beta-1 receptor stimulation, increases heart rate and contractility. And so for choosing a specific vasopressor therapy in patients who present with this type of overdose, epinephrine and dobutamine are going to be used more in cardiogenic shock, where norepinephrine is going to be more in vasogenic shock. And there is some evidence to support the use of vasopressor therapy in patients that present with this type of overdose. Specifically in the guidelines, there's a retrospective chart review from 2013 that looked at 48 patients that had verapamil or diltiazem overdose. And they looked at patients that were admitted to a talk service following an overdose of these agents over a 14-year period. They looked at the demographics of the patient, the drugs that were ingested, their initial blood pressure, pulse rate, whether or not they required mechanical ventilation, any ischemic complications and outcomes that occurred. Then they looked at the different agents that were used, their maximal doses. And they also documented whether or not high-dose insulin therapy was added on. So around half the patients had overdose specific to verapamil, and then over 50% of the patients that were included in the trial received some sort of vasopressor. Use of multiple vasopressors was common. The most common agent was norepinephrine. There were 8 ischemic complications that occurred in 5 patients and 3 cases of acute tubular necrosis. 1 patient had a late arrest and subsequent death. 47 patients recovered, and only 3 patients that were included in the trial received the insulin therapy. And so they concluded that the use of vasopressor therapy and calcium channel blocker overdose wasn't detrimental, and that vasopressor use in patients with calcium channel blocker overdose can offer blood pressure support in cases of shock and should be used as a first-line agent. And this is kind of extrapolated into the beta blocker overdose group as well. And then the second first line therapy that we see recommended is this hyperinsulinic euglycemic therapy. So um, again, this therapy in combination with vasopressor therapy is the only one that's recommended as like a higher level therapy for patients who present with this type of overdose. Essentially, we're restoring glucose uptake in cardiac cells and shift metabolism back to carbohydrate utilization to eventually improve inotropy and cardiac output. So there are a couple of different reviews that kind of look at how to dose high dose insulin, the effect that it can have with as far as clinical outcomes and monitoring. So the first was from a retrospective chart review from 2018 that looked at 199 patients treated with high dose insulin, either for beta blocker or calcium channel blocker overdose. This was at a single poison center, but it was one that spanned over 2 states. And their objective was to define dosing ranges and protocol for high dose insulin therapy, identify associated adverse events that came along with giving high dose insulin therapy, and then assess overall outcomes in patients treated with high dose insulin therapy. Some of the clinical outcomes they looked at were acidosis, asystole, bradycardia, cardiac arrest. They looked for conduction disturbances. They looked at electrolyte abnormalities. They looked for mortality, and then they looked at safety, such as like the metabolic adverse effects. So specifically, they targeted hypoglycemia and hypokalemia. Um, as far as outcomes, 31 of the 199 patients died during the study, but the deaths were not directly related to the therapy. And then more hypoglycemia as an adverse event was more common. They found in the beta blocker overdose for a group versus the calcium channel blocker overdose group. Um, and then hypokalemia occurred in 57 of the 199 patients, and that outcome was pretty well split between groups. The majority of patients had adjunct therapy with vasopressors, specifically norepinephrine, and then about 21% of the patients experienced cardiac arrest. As far as dosing strategies that they found were most common, the median weight-based dose that was used was for bolus was 1 unit per kilogram, and then the median starting weight-based infusion was 1 unit per kilogram per hour. The median peak weight-based dosing was 8 units per kilogram per hour, and then the median days of therapy with high-dose insulin was 2 days. 184 of the 199 patients required dextrose, most commonly D50 and then D10 in the calcium channel blocker group as well. So they recommended essentially that high-dose insulin infusion is safe and feasible if monitored and at these specific doses as following supportive care with vasopressor therapy. Again, it requires close monitoring and treatment of hypoglycemia, which occurred pretty commonly, but more data would be needed to compare outcomes between patients who received and did not receive this type of therapy and overdose. And then the next review was one published in 2022, which was a retrospective case review at a single academic medical center, looking at outcomes in calcium channel blocker and beta blocker overdose before and after the implementation of a high dose insulin protocol implementation. So prior to the study, or essentially what they were comparing was patients who were treated with high dose insulin without this protocol in place, and then patients who were treated with the protocol in place. They had 10 patients pre-guideline and 17 post-guideline. And the majority of the population in this case presented after overdosing with metoprolol. Essentially, the protocol gave them they put insulin in a higher concentration in a bag compared to what they normally did. So their normal was 1 unit per ml to 10 units per ml, and they gave it as a 20 units per ml solution, and then implemented monitoring parameters for it. So in the post-guideline group, the hypoglycemia in the pre-guideline group was more common than in the post-guideline group. Hypokalemia was more common in the post-guideline group. And then they also looked at volume overload. So the theory was that if they gave this higher concentration of insulin therapy, they'd have less volume overload in patients post-guideline. Um, and that didn't seem to be the case in their study. Um, and essentially what they recommended after looking through all this data was that implementing the high dose therapy protocol was beneficial. It essentially demonstrated that strict monitoring was needed, protocol was needed when giving this type of therapy. So at our institution, we do have a high dose insulin protocol for these patients. You start with a bolus of 1 unit per kilogram, and then you can start the infusion at 1 unit per kilogram per hour. It's titrated up by 0.5 units per kg per hour every 15 minutes with a max dose of 10. We're titrating to maintain a MAP over 60. And then we also replace dextrose when we give this type of therapy. So you can give a bolus, and then it's more specified in our protocol specifically as you select down. But we do 50 gram and 25 gram or 12.5 gram boluses of dextrose. Typically when we do the infusions, it's D50 to D20. And our goal is to maintain euglycemia at 150 to 250 when they're on this therapy specifically. For monitoring, we look at blood glucose. If the blood glucose drops below 100, we hold the infusion. We check every 5 minutes for the first 3 checks, every 10 minutes until our blood glucose is over 150 for 3, and then every 30 minutes until over 150 for 4 hours. And then we go to every hour. And then we also look at potassium to monitor for transient hypokalemia. So we have to be very cautious when giving potassium replacement in these patients, because once we take the drip off, and you've over replaced the potassium, it'll shift out. You'll have a shift out of your cells. You'll get super hyperkalemic, and so we replace with 40 milliquivs of calcium chloride if the potassium drops below 4, and we replete very cautiously when we do this type of infusion. If it drops below 3, then we would hold the infusion and replace it before restarting. Okay. And so then we're going to do our second knowledge check. So by what mechanism would the administration of high-dose insulin to improve a patient's cardiac function and calcium channel blocker and beta blocker overdose? Would it be increased carbohydrate utilization and glucose uptake in cardiac cells, causing catecholamine release in adrenal glands, binding in an activating drug at toxic levels to remove, or antagonizing beta adrenergic receptors? Yeah, it's A. So essentially, because we shift our metabolism back to glucose utilization when we give the insulin with the dextrose. And then real quickly, when we're weaning it off, you decrease by 0.5 to 1 unit per kilogram per hour every 30 minutes with frequent checks of your potassium, and the dextrose infusion is continued until after the insulin infusion is weaned off. And then just to talk about some of the refractory therapy that we use as well. Before you move into any of these, it's recommended just to optimize the therapy that you have now. So make sure that you're using vasopressors. If you can use the high dose insulin, the max dose is 10. If none of your other therapies work, then we'd move into sort of the next couple of treatment options. The first is methylene blue. It causes nitric oxide inhibition and CGP-mediated vasodilation inhibition. We dose at 1 to 2 milligrams per kilogram over 5 minutes, followed by 1 milligram per kilogram per hour infusion with a max dose of 7 milligrams per kilogram. but we have to be careful. It can cause serotonergic toxicity at high doses and induced methemoglobinemia. This is a level 2B recommendation for refractory vasodilatory shock, specifically in calcium channel blocker toxicity. And then IV lipid emulsions, which we kind of talked about at the beginning. So these are recommended as, or this is recommended as refractory therapy, specifically in European guidelines. In the AHA recommendations, they aren't positive that there's any benefit at all, but this is kind of like throwing everything but the kitchen sink at it. So evidence supporting the use of intralipids is limited. We mostly have case studies. It's better in lipophilic medication overdose, so like propranolol or verapamil, and then multi-agent overdose if you don't know what they've taken, and refractory shock. Essentially, we're creating the lipid sink phenomenon. So we're drawing the drug away from the heart, increasing calcium levels at high concentration, and it causes positive inotropy. It's a 20% lipid emulsion, a 1.5 milliliter per kg bolus, followed by 0.25 milligrams per kilogram per minute for 30 to 60 minutes. And the max dose is, I believe, 12 milliliters. Potential adverse effects with IV lipid emulsions are things like pancreatitis. If you have a patient that does have to go on to ECMO, it can interfere with your ECMO circuits. It can cause a sequestration of other lipophilic medications and interfere with lab values, including triglycerides, lipase, lactate, and your pH. And then VA ECMO specifically is reserved as a last line therapy for cardiogenic shock that's refractory to other therapy. Essentially, we're just trying to take the heart's job over by pumping blood and oxygenating our blood in the arterial system. And this is basically just trying to get our patient stabilized until they can recover. So what is the proposed benefit when giving IV lipid emulsion therapy in calcium channel blocker and beta blocker overdose? Yeah, right. So again, we're creating a sink phenomenon to sequester the toxic agents when bound to the lipid formula, so they're not available for uptake. And then we're going to go into sort of a mini patient case. So DM is a 54-year-old male with a past medical history of hypertension, hyperlipidemia, AFib, and major depressive disorder. Has no significant family history. Takes sertraline, verapamil, metoprolol, and Eliquis at home. He arrives in the ED following a suspected overdose around 4 hours ago, but EMS is unsure which home medication he took. Which of the following collective lab values would help indicate which home cardiac medication the patient took? Yeah, B. Um, so the labs and vitals are taken. Relevant labs and vitals include a blood glucose of 200, a serum K of 5, a serum calcium of 8.4. His heart rate is 32 beats per minute, and his blood pressure is 70/80, with a respiratory rate of 10. So when you look at this patient, what treatment options may be chosen as first-line therapies to treat his condition once we've done our initial management and have gotten him sort of stable? Yeah, so remember, like recommended for both beta blocker, calcium channel blocker overdose. The high dose insulin and vasopressor therapy are going to be the two that are recommended first line after initial management before things like methylene blue or ECMO. IV calcium can be used in calcium channel blocker overdose for bolus therapy initially. Lipid emulsion therapy is a refractory therapy, and gluconate is not used. So just to summarize, calcium channel blocker and beta blocker overdose have similar presentation, with the exception being hyperglycemia that occurs more in patients who have calcium channel blocker overdose. Supportive care and beta blocker and calcium channel blocker overdose involves a variety of therapy that's based on sort of weaker evidence, case series, case reports, animal studies, and studies that have mixed results. The therapies with the strongest evidence include the high-dose insulin therapy and vasopressor support. And then if choosing to use high-dose insulin therapy, it requires close monitoring, but you could see a benefit in restoring cardiac output and inotropy. And then refractory therapy, if none of these options work, are include IV lipid emulsion therapy, methylene blue, and VA ECMO. And then I'll take any questions.
Is there anything in our current approach to treating these overdoses that, based on your review of literature, you think we should optimize or change?
I think we do a pretty good. So the question was, if we think there's anything here specifically that based on this search we could do better, optimize, or change. I think we do a pretty good job, especially from what I've seen, as far as like getting people on vasopressors when they come in. And then I haven't seen that many in practice, but our protocol for the high dose insulin therapy is very like well thought out and detailed. You have to like when you're on Epic, it's in an order set and it guides you through the order set. I think we do a pretty good job at implementing it in a dose that's correct and that are at like with safety monitoring that is safe, if that makes sense.
I have one more question.
Yeah.
Sorry. So once upon a time, we may still do it, but once upon a time, we kept a bag of glucagon in a big plastic bag that said 4 overdoses. Do not use without contacting Amanda. Fun fact, because there was a glucagon shortage. You're laughing, but you remember that. Is that something based on these treatment patterns that we still need to have like designated stock set aside for your
Glucagon. Um, I mean, I haven't seen it given. I know we give it. Again, I don't have as much experience as like maybe like Tab or Jeff would have in treating overdoses like this. But from what I understand, it's mostly that would be like in an emergent setting versus someone who goes up to the floor. So the benefit of having like a backstock of it probably isn't like that high, if that makes sense. Yeah. Yeah. I think that the kind of the point is that there might be a benefit, but it's like a very small benefit. So you'd have to, again, it'd be like if they're on ECMO and can clog the circuit, what's the risk of having that happen versus just giving them lipid emulsion therapy? It can affect your triglyceride levels. So your triglyceride levels can get really high, and then we have to stop it anyway. So if at baseline that's high, it's probably not. Again, benefit has shown to be pretty minimal. So the risk might not outweigh the benefit there as well. And then if you have like other lipophilic medications that you're giving that you don't want sequestered, again, like risk versus benefit. If you're taking away a benefit from a drug that's doing something, is the maybe very small benefit of giving the IV lipid. I think it's a very last line sort of recommendation, if that makes sense. Yeah.
Excellent job. Well done. Right. This is a question of if you have patients suspected overdose and a low map, we have a norepinephrine and against the therapy. Is there any differentiation in the protocol when to go about which one or the breakdown?
Like when to go up on each one?
When do you use norepinephrine versus
I would have to look into that because I didn't super check, but I'm gonna make a note because that's a good question. And I will get back to you. I do know that the MAP goal for the insulin therapy is the same usually that we use with vasopressor therapy, and you come off the vasopressor therapy before you come off the insulin therapy. Yeah.
Insulin drip.
Oh. Um,
Maybe a better question is, why would you want standard 1 milligram per ml concentration?
because of like if how much fluid you're giving. Essentially, you don't want to like fluid overload somebody, and because that's going to affect your hemodynamics. Hmm. It's a higher concentration. Anything else? Okay. Thanks. I have the CE code also.
Yes.